Hi, everyone. Are everything okay, Christina? To start this conversation, it's an absolute delight and a pleasure to introduce Dr. Eida Castro. She is an associate professor at the Ponce Health Institute in Puerto Rico, clinical psychologist with a training in translational research. Her institution is a partner with Moffitt Cancer Center and also our partner. Her expertise is on cancer disparities in Puerto Rican communities, community-based training and engagement of community members, community health workers, and community academic partnership. Her research expertise is on mental health and symptom management, in which today she's going to be presenting us the impact of natural disasters in COVID on the context of supportive care with cancer patients. I'm thrilled to share that University of Rochester and Wilmot has a partnership with Ponce, which we are formalizing now in a memorandum of understanding. So looking forward, thank you. Eida is also a friend who is in Rochester, enjoying very much the great weathers and all the things that we have to offer here. So with that, Eida, it's with you.
Hi. Hi, good morning. Well, good afternoon. So it is a pleasure for me to be here. And, you know, I've been collaborating with Paula and her team for a while. And now that, you know, they are here in Rochester, and knowing that there's also other opportunities to collaborate, particularly with the Hispanic population and Puerto Ricans, for me has been a thrill. So I just want to share with you the work that we have done in Puerto Rico and with cancer health disparities, and basically, you know, just providing like the syndemic view of cancer health disparities in Puerto Rico. So just to give you some percentage of objective, I will briefly discuss the syndemic framework, provide a brief overview of the Puerto Rico cancer statistics and socioeconomic and political status, and argue why, you know, I feel that this endemic framework can provide a comprehensive approach to understand disparities. And of course, you know, in this framework, I am also going to include our experience with research in the area of, you know, of natural disasters, pandemic, and disparities. So just, you know, I have no conflict of interest to disclose. I have received funding from the National Cancer Institute and the National Institute for Minority Health and Health Disparities, and these projects that I'll be presented, most of them were funded by those two institutes. So just to give you a brief overview of the syndemic model, this is a model that initially was applied to HIV, on the HIV epidemic, basically, you know, trying to understand how contextual factors such as, you know, drug abuse and violence, for instance, it was a driver for the HIV epidemic. And this, after that, this has been also applied to other conditions, although in cancer there has not been that many. So that's, you know, one of the reasons why I feel that this is also that can be also applied to cancer health disparities. So this is a model that involves the clustering of two or more diseases within a population, in which there are contextual and social factors that create the conditions in which these two diseases are clustered. And the clustering of these the results of this disease clustering result in adverse disease interaction, either in the biological, social, behavioral, and of course increasing the burden, the health burden. So here is how I, you know, conceptualize how it applies to disparities, particularly within the context of Puerto Rico. We have cancer, which is the disease that we are studying, but there's also comorbidities with mental health and also chronic multimorbid and comorbid chronic conditions. But in Puerto Rico, for instance, there's some social and political circumstances that I believe that are also driving these disparities. One of them is the Puerto Rico economic crisis, in which I will be discussing a little bit more about that. Of course, the exposure to natural disasters, of which we have had two, an earthquake and also a Hurricane Maria. The COVID-19 pandemic, which was global, and social environmental adversity. And for those of you who are not familiar with this term, it is usually used to describe communities and population that are exposed to extreme chronic events such as poverty, for instance, exposure to crime, sexual and physical abuse, domestic violence, child abuse, and other conditions. And this is, we know that these also are high when there are conditions of low, economic crisis and also this social adversity. So, and of course, this drives other cancer health disparities. So just to give you a brief about, a context in terms of cancer incidence in Puerto Rico compared to the United States. In terms of incidence, incidence is not, at high, it's pretty much the same as, many states. So there's no difference there. So is more cancer mortality. However, there are some types of cancer in which in Puerto Rico, there's more incidence. For instance, cervix cancer, colon rectum cancers, prostate cancer, thyroid, and stomach. And in terms of mortality, there are higher mortality rates in Puerto Ricans with liver, colon, rectum, prostate, and stomach cancer. So these are, differences. Just to give you a little bit more context in terms of cancer incidence by region in Puerto Rico, where my university is the Ponce, where the Ponce city is, the south part of the island. So in terms of incidence, there it is less than in other areas, such as, for instance, here where the San Juan metropolitan area is. However, when you see mortality, you see that in the Ponce region, there are higher mortality rates in this area. And one of the potential reasons might be, in general, for instance, although, we're the second largest city in Puerto Rico, we serve a lot of communities that are rural. I'm going to show you in the map later on that, the central part area of Puerto Rico is a mountain ridge where there's a lot of rural communities, and that might be also one of the drivers of that. So just wanted to give you a context of where Puerto Rico are. I know many of you know, but we are in the Caribbean Sea, between the Caribbean Sea and the Atlantic Ocean. Puerto Rico, this is the mountain range that I was just telling you about, how close is to Ponce. This is the second largest city, as I mentioned, and this is San Juan. And we are, in terms of political status, we are a territory of the United States, and we have been American citizens since 1917. And I always post that because sometimes, there are people that don't really know that we are basically, as American citizens. It's been more than 100 years. And the population is roughly 3.3 million. We have more Puerto Ricans in the United States than we do have in the island. And I know that Rochester is an area where you have a lot of Puerto Rican here, and population have dropped significantly in the past years due to many factors that I will explain. So in terms of how, where the habitants, you can see here, this is the San Juan area where the city is. In the capital of Puerto Rico, like 1/3 of the population is living in the city, 1.2 million inhabitants. In the Ponce area, particularly in the city, 149,000 inhabitants that live in the area. So basically, I wanted to give you a brief of Puerto Rico, the inhabitants, and cancer. But also I want to talk about the economic crisis, which is one of the drivers, of the social conditions that I believe that also impacts disparity. The island has been struggling with the sustained economic recession since 2007. So it's been 14 years since we've been struggling with the economic crisis. The economic gross national income of Puerto Rico is $25,000, which is very low. And if you compare it with the poorest states here, and also in some US territory, is also very low. And this is for the whole island. If you go maybe to some other towns in Puerto Rico, this gross income will be lower than that. And the drivers sustaining this Puerto Rico crisis has been the government overspending, escalating debt that have compounded to $70 billion. And right now we are in a file bankruptcy for the government, and we have under an fiscal oversight board appointed by the president of the United States because of this crisis that we have had in this debt. From 1996 to 2006, the U.S. Section 36 tax incentives with incentivated manufacturing companies phased out in Puerto Rico, and many of those back then in Puerto Rico, the manufacturing company was a large contributor to our economic, and they just left this company. So many people were unemployed, and of course, a big sector of the economy just left the island, and that actually hindered our economics. It coincided when the great U.S. economic recession started in 2007, and definitely the recession compounded Puerto Rico's debt and the economic crisis. And before and after Maria, there has been a massive migration of Puerto Rican to the U.S., especially middle class, educated, skilled, younger residents, and also children's birth have dropped in Puerto Rico, and that have caused for the a decline of the population of 11.8%. And if the productive citizens leave the island, definitely, we're not going to be also seeing a growth in the economic, and our population is aging. We have more aging population in Puerto Rico. So these are, those drivers that have hindered the economy, and that also, have impacted cancer health disparities in my argument, with my opinion. The Puerto Rico health system was impacted by these, and of course, before the economic crisis and because of the economic crisis, between 1970s and the 1990s, the health system in Puerto Rico changed from a regional public health care system to a private, decentralized, and fragmented private care, which we know that when the healthcare is fragmented, it definitely has an impact on not only access to care, but also the quality of care. And due to the Puerto Rico healthcare system structural changes over time, quality of services have diminished. There has been a privatization of the public healthcare systems, which have risen the cost of care. And I know that this is something that also in the US probably you have experienced. But on top of that, the mass migration of health specialists to the United States, many physicians and specialists, with some type of specialists in healthcare have moved here. And we lack now that they're in Puerto Rico. And the aging population have a higher incidence of chronic conditions. So definitely the healthcare system has been impacted by these changes. And before I continue, I just want to consider some key data, and it's the intersection between economic crisis and health. And I want to pay attention to this meta-analysis that was conducted in Greece. And the reason I bring it is because Greece is also, islands that have been also within a deep economic crisis. And in the beginning of our economic crisis, we were lot, many times compared to Greece. In this meta-analysis, they found that crisis-driven deterioration of public health led to increasing rates of mental health disorders, suicide, epidemics, and deterioration of self-reported health. And, which, it is also have happened in Puerto Rico. And also pay attention to the social and environmental adversity paradigms and health, in which, in this case, for instance, individuals, it has been known that individuals that are exposed to, for example, childhood adversity, are more likely to be severe obese, smoke, have self-rated health complaints, use drug and alcohol, depression, commit suicide, and develop heart diseases, and upregulation of the inflammatory activity. And socially vulnerable communities that have experienced natural disaster are more likely to have higher incidence of poor mental health and physical health, higher blood pressure, and asthma. And also, this is very interesting, what this study found, that the incidence of this poor health outcome increased each time, each year a community is exposed to a natural disaster. So definitely, when we apply this to Puerto Rico, we can see that it can also be, drivers for these disparities. And in Puerto Rico, we have been in less than 4 years, we have experienced a massive hurricane, earthquake, and of course the pandemic, increasing that vulnerability. Like I put here, natural disasters. So we know that cancer, already we know that patients that, people that are diagnosed with cancer, they're more prone to, to have mental health, potential mental health conditions due to the cancer experience, some treatments that also have these effects on the mental health, and many people that already come with mental health diseases. So definitely this is something that we know that is more prone in cancer patients. For instance, in this study meta-analysis with cancer patients that were in acute care, 46% would have reported mental health disease. Depression and anxiety has also been associated with the risk of cancer incidence, specific mortality, and all-cause mortalities. Survivors have higher prevalence of depression and anxiety symptoms, and Hispanic are most vulnerable of having these symptoms. And my point here is that cancer patients are already vulnerable to mental health diseases and distress. So when you add these other drivers, due to the social conditions, it'll be, it will be like the perfect storm in terms of exacerbating these conditions. And of course, having a cancer diagnosis will also make you more prone to have comorbid condition. And again, when you're exposed to this, it also make it a risk factor to that, in our hypothesis. So the research work that I'm going to be presenting is part of the of our, some of them part of our collaboration with the Ponce Health Science University and the Moffitt Cancer Center, where we have for the past since 2006 we have collaborated and developed an infrastructure of cancer research, not only on prevention, also in mental health outreach and biology. And the first one I want to share is this very first project that we conducted when we started the partnership. We started, there is a cancer outreach core that is led by one of my colleagues, Dr. Julio Jimenez, who is going to also visit here Rochester and very soon. And we started this, when we started this cancer outreach core, initially we partnered with different community leaders, organizations, healthcare professionals, and we wanted to started doing these forums and focus group and forums, and we wanted to see, what were their needs and how, how could we address this need through the partnership. And after all those conversations we held for many of them, we identified that there were some areas of needs: financial, insurance concerns, transportation, access to pediatric oncology services, psychological, spiritual support, challenges navigating the healthcare system, improvement in physician-patient communications, and cancer prevention and education. And just wanted to bring your attention, this partnership started officially in 2006, just, a year after the economic crisis started. So when we started this, there was already, a economic crisis that have boiled up in Puerto Rico. So these were the needs that were identified. And so based on that, we conducted another study, because we, and this one, was a group that conducted, in which we wanted to identify what were the clinical and support service resources and their network practices for patients and survivors in Puerto Rico, because we were already hearing about these challenges, but we also wanted to do like an inventory of what are the services in the southern part of Puerto Rico where we were impacting, and how they're interacting, and so that's how this study came up. And what we found out is that this is a map of the distribution of the organizations that we surveyed. It was a total of 54 organizations. And what we found out is that most of them, their physical facilities were in Ponce, the second largest city, but they provided services to different areas in the island. Of course, you remember the many of those community partners mentioned about the transportation challenges and also access, because most of those headquarters was in Ponce. They had to get transportation to get services there. So there we see also some challenges. And also we wanted to assess what were the practices in terms of interacting. We identified that 24% informed that their services were exclusively to patients diagnosed with cancer, and with this, no mental health services were exclusively for cancer patients. 43% of the organization reported the practice of generating referrals to mental health services, and the most common organization interaction were referrals. So what we're seeing here that, when we conducted the study, not many specialized, particularly psychosocial support care to specialize to cancer patients and survivors, and no mental health. And we know that, as I mentioned, mental health is very prevalent in cancer patients and also survivors. And the other thing is that referrals for mental health, 43% it's very low of the organization doing this referrals. And since we know that it's very prevalent, probably there was no screening for mental health, and still is not that common. So I think, that was another problem that we identify. And also interacting the interaction in terms of referral, which, is a good start, but, they were not interacting more often or collaborating in there. So that, we saw this as some challenges in this system. After that, we conducted a study in which we wanted to know, how important the psychosocial needs of cancer patients and their importance. And then, what we found was that in the among other things, that the cancer patients, provided the lowest importance for the emotional and spiritual support. And of course, we saw this knowing that there were challenges in the healthcare system, that we provide also stress to cancer patients, that mental health are also very prevalent in cancer patients, and they're not being referred as often. Just looking at in this data and seeing, the patients may not be given, the highest importance in terms of the emotional and spiritual support, that, you know, also would be a problem in terms of identifying and getting referred, and also having patients uptaking this service. This is a study that my colleague Julio Jimenez conducted in the on hospital patients, cancer patients hospitalized in a general hospital. And what he found is that 65.5% met the criteria for a mental health disorder. And remember, you know, there was a meta-analysis that I showed before that they found that the rate was 46% of cancer patients in acute care with mental health. So here we see that in this sample, the diagnosis was higher in this Puerto Rican cohort. So after that, you know, we also conducted other studies, and here, you know, I want to present some data on 3 projects that we have been doing. One of them is directed to looking at social environmental adversity, which is the project number 1, Biopsychosocial Predictors of Tumor-Associated Inflammation. The other one is about Hurricane Maria and what were the needs and post-hurricane care after Hurricane Maria hit Puerto Rico. And the other one is a supplement that we were funded to see, you know, the impact on the COVID and also the earthquake in cancer patients. So the first one, this is the pilot project that initially was served as a pilot data for the biopsychosocial predictors, and that includes the social environmental adversity. In this pilot project, we wanted to investigate the relationship between comorbid depression, anxiety, and social environmental adversity and immune cell infiltrations in the tumor microenvironment of Hispanic breast cancer patients. So basically, we wanted to see, you know, if women that were exposed to social environmental adversity before the diagnosis of breast cancer would have, you know, at the time of diagnosis and of care, comorbid depression symptoms and anxiety, and also we asked for tumor samples. And I have my colleague, Dr. Guillermo Armaiz, who is a cancer biologist and have done a lot of research on stress and hormones and how that drives tumor growth. He would just be looking at immune cells that are usually related to cancer outcomes. So what we found here is that in this sample where the group that reported being exposed to adverse childhood events, child abuse, and had anxiety symptoms at the time that they completed this study, they would have, more quantified macrophages, B cells, T cells that were elevated, you know, and elevated history of depression. So basically, you know, even though this was marginally significant, it is a small sample for us, you know, it was a signal that the adverse childhood events plus the anxiety group presented the most infiltration of these 3 types of immune cells. And so these, you know, would be like an indicator of what is called the syndemic interaction, you know, that needs to be, you know, studied further, which is the co-occurrence of a social and health condition, including social, psychological, social, biological, and psychological, biological interaction that worsens the condition of the person or population. Basically, you know, how, you know, this social conditions, which is the adverse childhood events, might not only affect the mental health, but also the biology itself. So after that, we, as I mentioned, that was a pilot project that that informed this project, which is currently funded by a U54 RCMI full project grant. This is a project where we're actively recruiting. It's a total of 175 participants that we're going to be recruiting. In this one, we want to investigate whether current depression and past history of depression and exposure to social environmental adversity correlate with tumor-associated inflammatory processes in the tumor microenvironment. We want to map the trajectory, the 12-month trajectory of biological variables and also psychological variables, and define the contribution of pre-cancer stress and stress-induced breast cancer progression in animal models. So I want to show you just, this is data that from my colleague, Dr. Guillermo Armaiz. This is pilot data on his animal model. In this one, what he's doing here is mimicking what we have found in the pilot project, but in an animal model that he developed, and he and his lab. In this one, he had two groups of mice, one that were exposed to restraint stress and the one with no restraint stress. 1 month of no treatment, he injected breast cancer cells, and then divided it into restraint stress and no restraint stress. But what I want you to pay attention here is that in this, he then sacrificed the mice and extracted the tumor and measured the tumor volume, the breast tumor volume. So what he found is that in the stress pre-cancer and stress post-cancer condition, this tumor was with a higher value than the other conditions. So basically, we are translating this to human data, because this is like the animal model of what would be the social environmental adversity before having a cancer. And then on our clinical data, which we are collecting now, including the data from the pilot project, we wanted, we're seeing in these women that exposure to these adverse events, crime, disasters, and physical and sexual abuse is high. 50% have reported that they have been exposed to crimes, general disasters, of course, most of the sample, and physical and sexual abuse, 58%. And also here, we can see that in the exposure to adverse childhood events had also been high, especially, if we combine, those that have experienced at least one is roughly 80% of the sample if we sum, these three. But particularly, I want to pay attention to this group here, which 35% have reported that they have had exposed to 4 or more adverse childhood events, which is chronic. And although this is a small sample, and we'll see if this will continue, just if we compare, for instance, of Latinos in the study of Latinos, SOL study, the percentage was 28.7%. Still, it is a small sample. We're going to be recruiting 175, and let's see if this also, applies to the whole sample. But here we can see, how at least, I bring this as an example of how potential conditions of social conditions that might even be probably not only affecting mental health, but the behavioral of cancer, of the tumor as well, which is, what we are studying. These are symptoms of depression, anxiety of the sample, and still, they're also high, small sample, but, just to compare here, but we're seeing this trend. And so, we think that we'll see, if this continues, and then eventually how that also relates to the we're collecting tumor samples of these women also, and then we're going to also see if we see those markers correlating with experiences to adverse events and depression and anxiety. So now I want to move to the Hurricane Maria, which hit Puerto Rico in 2017. This was a Category 5 hurricane that killed an estimated of roughly 3,000 Puerto Ricans and cost approximately $90 billion in dollars in property damage and widespread devastation, long-term blackouts. There were areas in Puerto Rico that were a year without power, electricity, especially rural areas that were very, impacted. extensive structural damages and food shortages as well. So our team conducted a study and published this paper. This was with the initially we were funded by the Cancer U54 grant, a seed money to do a pilot study just right after, like 2 months after the hurricane hit Puerto Rico, and we want to see, what were the impact of the natural disasters, especially in the mental health and access to healthcare. So this paper that was published was based on that pilot data on patients that were, I think recruitment was like 2 or 3 months after Hurricane Maria. And definitely, what we found was that cancer survivors reported higher barriers in access to care compared to non-cancer patients, of which, we know that it definitely impacted their access to healthcare, which we know that eventually that would have direct impact on cancer patient survivor health. This is a dissertation study that was conducted by Ruth Maria Hernandez, who is a postdoc here, and she did a psychometric analysis of this hurricane hazard inventory that our team developed for the Hurricane Maria project. And what she found was that there was 2 factors that actually come together with the scale: the secondary hazard, which is the loss of electricity, the food, lack of food safety, which are secondary hazards of and the natural disaster, and the tertiary hazards, which is more related to interpersonal losses and loss of personal space, support. And that what is very interesting from this study is that when she did a moderation model of the scale and some psychosocial variables, she found that tertiary hazards were more related to anxiety and depression. So in here, we know that when people are exposed to natural disaster, mental health is definitely impacted. But what this study have done is that identify what specific hazards of this natural disaster impacted mental health, that then definitely will also impact quality of life, in this case of cancer patients and other drivers of health, and health equity. This is data from the baseline data from the patients, the larger study of cancer survivors exposed to Hurricane Maria. We continue recruiting, and then we have done follow-ups up to 24-month follow-up on this cohort. So this is the baseline data, and you can see here that definitely, compared to non-cancer controls, of which they were matched, the controls were people without cancer that were matched by age, sex, and also zip code. And we see here that definitely, cancer patients had more, symptoms of depression, anxiety, and PTSD as well, and this difference were significant. And these are just, to give you a longitudinal changes in terms of symptoms of mental health and barriers to care. This is baseline data up to 24 months, and very interesting what we see in here is that initially this is cancer patients compared to control. Initially, cancer symptoms of depression, anxiety, and perceived stress were higher than the control group, but then it diminished over time. So there is this, very good news, because it means that there are, there's initial impact, but they tend to diminish over time. And then in the same with barriers to care. So just, what this graph shows is that how, the impact is just in this first month of after the natural disaster. It is. Also, this is baseline data on health behaviors, and just wanted to show how it didn't impact the smoking or drinking behavior initially. They, it was, but physical activity here, as we can see, 47% of participants reported no physical activities. And of course, we know that physical activities is also another behavior that can either promote health of deteriorate health. And in terms of comorbidities, for this sample for this secondary data and this secondary analysis is roughly 4 conditions of comorbidities, high comorbidities. Now I want to move to the earthquake and the pandemic. The earthquake hit Puerto Rico in January 2020, coincided with the pandemic. When we roughly 40,000 citizens living outside were living outside in their unsafe, damaged home when the pandemic started in Puerto Rico. So imagine starting a pandemic with people staying outside. And today, in terms of the pandemic, 210,000 Puerto Ricans in Puerto Rico have been diagnosed with COVID, and roughly 3,000 people have died because of COVID. We're also conducted, this is preliminary data from the supplement that we have conducted. This is the, this here is a manuscript in process that is being conducted by one of my postdocs, Dr. Cristina Peña, who is in Puerto Rico. And she was basically doing correlation of exposure to earthquake and barriers to healthcare. And definitely, it affected barriers to healthcare. That was, with cancer patients that were the follow-ups coincided, after the earthquake. And here, this is another analysis that we did, and we wanted to see, since we have data on pre-pandemic and earthquake and post-pandemic, we wanted to see if there were changes in terms of depression symptoms and also symptom burden. And interestingly, we found, although it is a small sample size, what we found is that there were changes, but they got better. And then significant changes in terms of depression and symptom burden interference. But it was, the cancer patients did better. So we wanted to know what drove this potentially, at least, potential protective factors, and resilience is the is what have also potentially have driven here, and potentially have also been driving the changes also in the longitudinal changes. This is another study we included. We used a survey that was developed by Paula and Francisco on the changes in behavior following the lockdown. We also have seen that there are changes, in behavior, but especially, physical activities and sedentary, again, which we know that this is a very important behavior that would either promote health or not. So basically, this is the data that, I wanted to present and make my argument why this endemic framework when applied to health disparities, especially, it is a comprehensive approach to understand disparity. Puerto Rico's unique social vulnerability, which is compounded by these factors, the economy, disaster, pandemic, and the environmental adversity, I believe is a perfect storm for perpetrating these disparities. And I think, that longitudinal, when I want to do like some continue following up this cohort and see, what would be the longitudinal impact of these of exposure to these unfortunate events in their health, and applying this framework will be very, very comprehensive. And on the bright side, we see resilience that could be, a very protective factors, and at large, Puerto Ricans, and I think that Hispanic community, we're very resilient and we have a strong sense of community. And I think this is an opportunity to develop interventions in which, we can leverage on this strong resilience that also cancer patients have and Hispanic community to address this, to enhance it, and to potentially, eliminate or reduce these cancer health disparities. So this is all for my presentation. I wanted to end with this and showing you this. This is a scenery in Puerto Rico, Cueva Ventana, window cave, and just to give you, like a metaphor of the window of opportunity we have here on these collaborations, particularly since we share themes in common, and then that you have a large population of minorities and ethnic minorities, particularly Hispanic, Latinos, and Puerto Ricans. So that's, one of the reasons of my visit here, just to expand collaborations. And also, I wanted to show you, that not everything is negative in Puerto Rico. There is a beautiful island. We have mountains and, a lot of scenery, and people are very welcoming, charming, and great. So I will welcome you to come to Puerto Rico now that we're collaborating, and see my island and vacation there also. And I just want to thank you for, your attention and for inviting me here. And now I am open for questions. Thank you.
Thank you so much, Dr. Castro, for your wonderful presentation. It was really great, and just so interesting to see the interconnectedness between all of these different factors and the effects on cancer. So I just want to let anyone watching, if we have a few minutes left here, if anyone would like to ask any questions, and I will go ahead and ask them to you, Dr. Castro, if any come through.
Yes.
And I actually just have one as we're waiting for other questions. That as you were speaking about this syndemic, what you talk about, this syndemic model, and about resilience. And does resilience fit into that syndemic model? Like, because I saw the model that you had had these different factors on it, but I wondered about whether resilience itself can fit within the model.
Yes, it can fit within the model in terms of, these factors that could be protective. And I believe it is called the counter resilience, I think is the term, because they have different terms, but yes, it does. And I think, when we look also at the protective factors, we also see opportunities for interventions, to enhance these protective factors, or maybe promote them if they're not being factored in. Resilience is also a protective factor when you look at data on social environmental adversity and trauma. Definitely post-traumatic growth and resilience and social support are factors that definitely protective factors on that. So in this population, definitely we can see that.
Great. I have another question here for you. It says, could you explain again what the reasoning is behind why cancer survivors report higher barriers in access to healthcare?
Yeah, so there are two. During Hurricane Maria, of course, a lot of patients were, we have access to barriers in many, across the board. So one of the reasons is many of these cancer patients initially were in active care, and usually they recur, to more active care. So when you have a natural disaster, for instance, such as Hurricane Maria, of course, there was no power for weeks or maybe months in some areas. So access to care gets hindered. Roads, there were many people that were did not have access to roads because they were I don't know how to call that in English, there were no roads. I mean, they just collapsed. So those are, the hazards, like the hurricane hazard or the natural disaster hazards that definitely would have an impact on access to care. Now, with the on the earthquake, there were barriers in access to care, but it was different than Hurricane Maria, but because the earthquake was on a southern part of the island, and back then there were the metropolitan area and other areas of Puerto Rico were not affected by the earthquake. So there, barriers of access to care was not that that a problem. But cancer patients, we probably use more the healthcare systems, especially if they are receiving treatment at the time. So that could be one of the explanations to that.
Mm-hmm. All right, we're getting a lot of questions coming in for you. So here's another one. My sister lives in Vega Baja, and when she goes to the doctor, she is at his office at 4 a.m. and is seen at 3 p.m. Is it like that on the whole island?
Yes, definitely. That's what I'm saying about, access to care. Remember, I told you about also a brain drain in lack of specialists. If it's a specialist particularly, you can not only wait for hours, but you would wait for months for a appointment. The hematologists, for instance, which are very short in Puerto Rico. And then, since many of these specialists have moved, they are serving more patients. And of course, chronic conditions are getting, the higher rates. So people are using more of the system. So that's part of the crisis and the consequences of that. And is in the whole island.
All right, I have another question here. Let's see. To what do you attribute the positive changes that you've seen in some areas of your research?
Well, I will talk about the resilience, after. So we were discussing this with the research team, especially when we saw that after 24 months, symptoms will be lower. And of course, we didn't expect that they would get better after the pandemic and the earthquake. And one of the things that we were discussing, which is open for research, is that the Hurricane Maria was so devastating. I mean, imagine you being in an island where you don't have any, not cell signal. You couldn't communicate with family members. You couldn't even get out of your area because all the roads were down. So it was really devastating. And that, at the least you were maybe 2 weeks or 3 weeks like that. There were people that were months. So the exposure and the trauma was even, unimaginable, the impact. So I think this is where resilience kicks in. And I think, it's a hypothesis that especially cancer patients that we were discussing this, cancer patients already have gone through a diagnosis that is related to death. And then they have to develop resilience for the treatment and that. So we think that maybe this is something like protective factor that probably cancer patients would have and develop more because of their condition. And then Hurricane Maria. And after we were exposed to the earthquake and the pandemic, it was not, in terms of access and mental health, it was not as bad, as it was Hurricane Maria. However, the point here is that we have seen that even though you might not be developing these symptoms, you were already exposed to stressors, and we don't know in the biology if you are already upregulated in terms of getting stressed, and so that's something that we are addressing through this collaboration between the behavioral, clinical, and the molecular part of the study. But we feel that probably they're more resilient because Maria was so devastating. We thought there was going to be re-experimenting the trauma, but at least this is a small sample size, so we don't know if also that drives that, but that is a hypothesis.
Yeah, it was interesting when you showed your data how there was the impact at the time of crisis. There was a strong impact, but then at least in Hurricane Maria, I think in the earthquake, that it then settled back again, you know, within a few months, really. Yeah.
Yes. And Puerto Ricans, you know, I think the Hispanic culture at large, you know, we tend to help each other, you know, and we unite a lot, and in times of adversity, everybody is a family member, and we just help each other. So I think, you know, that's also part of the resilience of this community, that we come together and we help each other. And even though we don't have, you know, we have lost things in that, we're just that type of, you know, we embrace the family and culture, and we expand it to others who have needs. So I think that's also part of this resilience that we're seeing is also embedded in our culture.
Mm-hmm. Well, we only have probably less than a minute, but I just wanted to get this one other question in here. Is it possible to expand on what types of tumor-associated inflammation you may find in this study being developed involving biopsychosocial factors?
Let me see if I understand the question. So can you repeat the first part?
Yeah. Is it possible to expand on what types of tumor-associated inflammation, you may find?
When you mean the type of tumor-associated inflammation, so and I'm not sure if it means the markers of other tumors, but if it's markers, yes. I think, you know, that there's room to expand, and this is something that you know, my colleague Guillermo Armaiz, you know, I think, you know, he will be happy to expand, and also expand in other areas of cancer, where inflammation also, like, for instance, symptom burden and all the things that I've been also talking here for potential collaborations. But yeah, it can expand to other cancer types also, patients that have been exposed to, you know, to adversity, and see how that, so yeah, there's ways to expand to other areas of cancer clinical outcome, definitely.
Well, thank you so much. I think we have a few more questions, but we're actually running out of time. So what we'll do is probably send you some of these questions, if you don't mind, and forward them on to the answers to all the people who've registered today.
Thank you.
So thank you, Dr. Castro. And I think Dr. Cartujano has a couple things to say.
Yeah, so first of all, thank you for the amazing presentation. We're very happy to have you here. I know that you have done a lot of research, but I think one of the things you missed in your presentation is your expertise on smoking cessation. So I think it's something worth to mention. We have been collaborating with Dr. Castro for the past 4 years now, and we have done studies in Puerto Rico to help Puerto Ricans in Puerto Rico quit smoking. And the results have been fascinating. So I just wanted to highlight that. And again, thank you for being here. Thank you for everyone who attended this webinar. And yes, Pamela, let's make sure that those questions get sent to Dr. Castro, and looking forward to possible collaboration.
Oh, yes, definitely. You'll see me here more often.
Thank you.
Thank you so much.
Hopefully, you know, you will also come to Puerto Rico.
Definitely.
Thank you.